Well, hello, everyone, and thank you so very much, conference attendees, for joining this panel titled Culturally Informed Approaches to Engage Latinos in the Continuum of HIV Care. We're going to be talking about approaches, interventions, frameworks, and we're going to be showing data, and we're going to be discussing healthcare service delivery challenges. We have a very selected panel. In a minute, I'm going to be presenting them. But for now, I am Jesus Felizuela, and I am a medical doctor by training. And I have spent half of my life, I would say probably 25 years in the United States doing research, program evaluation, capacity building in HIV with Latinos. I work in the pharmaceutical industry as a medical science liaison for the pharmaceutical alchemist. That is a hat that I'm not wearing today. I'm not here representing alchemists. I'm wearing my other hat. You know, I look really nice on hats, actually. So my other hat is as a research professor in the Department of Psychology at George Washington University in Washington, D.C. That's the hat I'm wearing today. We have a panel of 4 individuals whose work I know very well. So they're going to walk us through the many challenges that Latinos may face in entering and staying in the continuum of HIV care. So we're going to start with Catalina Sol, who is the executive director of La Clinica del Pueblo, and then we're going to transition on to Omar Martinez, as an associate professor at Temple University. He's going to address the topic of intersectionality and the development of interventions for Latinos in HIV. And from Omar, we'll go on to Serena Rejabian's presentation, who has selected the issue of employment and employment security or job security to basically show through data one of the challenges Latinos with HIV face in staying in HIV care. And last but not least, we will end the panel with Daniel Garcia, who is going to take a little twist on this to talk about the behavioral healthcare, housing, and employment challenges that Latinos may face in staying in care, with a focus on specific populations of subpopulation of Latinos, the ones that live and inhabit in Portland, Oregon. I would say a population that is not very well studied, like many other populations of Latinos. And without further ado, I'm gonna go ahead and give Catalina Sol the floor. And floor is all yours, Catalina.
Thank you so much, Jesus, for the invitation. And it's so great to be here with Daniel and Omar and Serena and with all of you who are have joined us today. So I'm Catalina Sol. I'm the executive director of La Clinica del Pueblo, and I am going to share some slides with you today. I'm very happy to be here in this conference in particular because I worked as the HIV/AIDS department director for 10 years at La Clinica before becoming a bureaucrat. So this is a very near and dear subject to my heart, and also one which I'm very proud to discuss as having been really owned by a wonderful group of staff at La Clinica who work in this area. So let me start here, and hopefully this will all work perfectly. No. Are you seeing Teams?
Yes, we can see it.
Okay, that's not what we want. Okay, let me close that out then.
We can see your presentation, Catalina.
Oh, you can see my presentation?
Yep.
The one that says culturally tailored strategies.
Yes.
We can, yes.
Okay, sorry. I get really paranoid. Okay, so one presentation, and it is called Culturally Tailored Strategies to Engage Hispanic Latinos in the HIV Care Continuum. Yes? Okay. So I am going to see if I can put this on the presentation format. Yes. Okay. So first, let me tell you a little bit about La Clinica. I'm very proud to say that La Clinica del Pueblo has been around for 38 years in Washington, D.C., and now Prince George's County. And we were founded initially in response to the waves of Central American immigrants coming to this country in the 1980s, fleeing the wars in our countries, El Salvador, Guatemala, and by association, Honduras. Migration waves which have continued and continue to dominate or continue to be the largest contributors of Latino immigrants to this Washington, D.C. area. We were a free clinic initially, and actually we became a Ryan White provider of HIV services before we became a federally qualified health center. But since 2007, we are also an FQHC, which is a clinic with a designation to provide services for low-income people in the United States, and really the safety net within this country for most medically uninsured and low-income people in the United States. And as our community has grown out of the district and in search of more affordable housing, have been forced to leave this sort of city of origin, we've also expanded our work into Prince George's County, which neighbors Washington, D.C. And currently we serve around 5,000 patients for our various care services. And we have a very broad community health facing work as well. So we on average have between 40 and 50,000 touches with community, including many people who we just can't serve within our doors. The majority of our patients are Latino and limited English proficient. And 34% are uninsured, mostly because many immigrants in this country continue to be ineligible for the federal safety net programs, such as Medicaid. Our model of care is, sometimes I think of it as a federation, but essentially we provide comprehensive medical services as well as entry points to care through mental health and substance abuse services. We have some school-based services, particularly working with newcomers in these most recent waves from Central America. And then, as I said, our community health facing work, which is both focused on health promotion, working particularly with promotores de salud, peer educators, but also on language access, language justice, and increasingly more organized, our work to change public policies that decrease our ability to produce and live in health. In terms of our HIV care continuum, La Clinica became a provider of HIV services very early on, after participating in the 80s in the HIV testing initiatives, which became required to become a permanent resident in the United States. This is how we identified many of our first HIV positive patients. And in 1994, we became a Ryan White service provider, which was a huge school for La Clinica, as with many organizations of that era. And we have grown not just our complement of services for patients living with HIV, but also our outreach, prevention, linkage to care, testing, PrEP, all of the areas which really are fundamental to have the whole continuum of retention, engagement, re-engagement of people who are at risk for or living with HIV have been a part of our services for a while. Within this, I'd say in the last 10 to 15 years, we've really had a greater focus on one of the highest risk groups within our community, which are younger Latino and Latina, gay, bisexual, transgender, LGBTQ, Latinx, who are actually for us became an expansion. We were mostly an adult provider. But as we took this leap to provide services that were culturally and linguistically appropriate for a younger population, we've really developed this area under our Empoderate program. And our Empoderate centers, we do have 2 locations, one in DC and one in Langley Park, very specifically create safe spaces for our members of our community to not only address HIV, but very specifically work with stigma, discrimination based on gender identity and sexual orientation. This building, La Casa, is our non-clinical site in Mount Pleasant Street. And this is a World AIDS Day outside of the Empoderate Center in ways in which we create visibility to a much larger group. I want to talk a little bit in terms of the strategies that we think are important in the context of COVID. You know, we have been a Ryan White and HIV services provider for decades, but COVID has been a huge area of innovation and response for us, as is the case, I'm sure, with many other service providers who are here. These are images that I think will be familiar to most of us in terms of how we deliver services and what we do and what we look like now. But very specifically in terms of our HIV prevention, recruitment, and engagement strategies, for us, COVID became an area of expansion in terms of service delivery modalities and specific services that we had really kind of stayed away from in the past. Home-based HIV testing was one of the areas that we took on first. And, you know, March of 2020 does not seem that far away, but it's really incredible how all of the other epidemics and pandemics that we've been dealing with just disappeared from our ability to address them. You know, as soon as we started doing home-based HIV testing, we identified 2 new identified positive young people who were, you know, living by themselves in their home and who received that support from a counselor. And one of them was linked immediately to mental health services because was suicidal, you know. So there's those interventions that we need to manage we need to maintain. While the world focuses on one thing, we continue to be multiple people, multiple people with multiple needs, not just the one. We also really, I think, defeated that assumption that we had made for many years that we would only be able to deliver services face-to-face. We found, of course, that there are many of people in our community who need and prefer on-site services, but we were able to reach much larger groups of people through our telehealth virtual services, not just for medical or mental health, but for health education, counseling, and for groups. These support groups during the pandemic have been vital for people to maintain connection, to have information and resources of all different kinds necessary for survival. Our condom distribution, well, this was a huge part of our work during the stay-at-home orders. We mailed them, and condoms by mail has become a really important part of our work. And I think as we were able to increase presence on our physical sites, our sites have become packaging centers. But of course, our work to the outside has been very essential as well. And I will say that La Clinica early on made the decision that all of our staff were health workers, all of our staff were essential health workers. And when PPE was very limited, we made it available to all of our community health workers and our non-medical staff, because the work that we did outside was as critical for being able to maintain health as what we were doing inside the 4 walls. We've developed a line of information and educational materials around COVID, which has really allowed us to, through social media, reach many, many more people than previously. And then I'd say that perhaps our signature and very beautiful production that has occurred has been a weekly series of sessions on Facebook Live around many, many areas of our, not just around HIV education, but just generally around COVID, resources, mental health, substance abuse, housing. And I'd like to show, if we have time, just a very short clip that is produced by one of our Empodera, the team, so that you get a sample of what really addressing stigma can look like when these interventions are developed by the people most affected themselves. So hopefully this will work. Can you hear sound?
We can hear, but we cannot see the video.
Hola, soy Emma y quería hablarles por un par de minutos acerca de algunas frases que he oído acerca de conversaciones sobre sexo.
¿Estás limpio?
I'm sorry, the video is not audible.
It is audible, but image is not there.
Yeah.
The image that is missing, unless that's all you wanted to show, Catalina.
No, I wanted to show the whole YouTube video.
Yeah. So you may have to stop sharing that screen, Catalina, and then do the sharing again. There we go.
Right.
Okay. Yeah. And now share the screen.
The video.
The screen, yeah.
Oh, I see. Okay, I'm going to, okay, I get it.
Excellent.
I'm going to start the YouTube and then share the YouTube. Okay, that's what I have to do. Okay, hold on. I am sorry. I hope I am not taking too much time. Okay.
You're doing just fine, Catalina.
Okay, here we go. Let's see if that works.
Yay.
Hola, soy Emma y quería hablarles por un par de minutos acerca de algunas frases que he oído acerca de conversaciones sobre sexo.
¿Estás limpio?
La mayoría de las personas usan esta pregunta para saber si alguien tiene VIH y no necesariamente están preguntando si acabamos de tomar una ducha. Usualmente significa que no quieren tener sexo con alguien que vive con VIH. Comentarios como estos aumentan el estigma sobre las personas que viven con VIH o están en mayor riesgo de contraerlo, como que si fuera algo malo. Además, muchas veces estas preguntas nos quitan la confianza para hablar de estos temas.
¿Qué debemos recordar?
Cuando nos señalan, discriminan o agreden, afectan la manera en la que nos cuidamos del VIH. Si vivimos con VIH o estamos en mayor riesgo de contraerlo, no significa que somos personas sucias, como tampoco implica que seamos ni buenas ni malas personas. Más bien, cuando las personas que viven con VIH toman su medicamento todos los días y mantienen una carga viral indetectable, no pueden transmitir el VIH. Por último, se vale buscar la información correcta para ayudar y promover comunidades más saludables.
Si deseas hablar más sobre estos temas, puedes contactarnos en la Clínica del Pueblo. Estamos aquí para ayudarte.
And so like this, there's a whole series. They're available in any of the links that we have. But the most important thing that I want to share, of course, is that what is the best way to engage our community is to let our community speak with their own voice. And so I will pass it on here with much pleasure to the rest of my panelists. And thank you very much.
Thank you so much, Catalina. Always a pleasure to see you presenting your work and the work of La Clinica, of course. Very near to my heart, of course. Next presenter is Omar Martinez. Omar is an associate professor at Temple University, and he's going to walk us through the concept or framework of intersectionality. And I'm just going to go ahead and let Omar do his work. Omar, floor is yours.
Excellent. Thank you so much for the invitation. Look forward to joining the conversation and the Q&A session. The title of my presentation is Structural Intersectionality and HIV Among Sexual and Gender Minorities. Here's the outlines of today's talk. I'm going to walk you through some epi data on HIV among Latinos, followed by a brief introduction to structural intersectionality as an approach that could help us address some of this in HIV among sexual and gender minorities Latinos, followed by 3 projects that I'm leading here in Philadelphia that address some of these structural barriers to HIV prevention and care. The first one is Connecting Latinos en Pareja. It's a couples-based biobehavioral HIV risk reduction intervention for Latino male couples, followed by Trans Equity Research Project, a homegrown intervention for men and women of trans experience, led by Galay, another organization that was founded in the 80s in the midst of the HIV epidemic. And I'm going to close it up with medical legal partnerships, a newly funded NIH proposal that we're working on for people living with HIV, and wrap it up with a few discussion points on future directions. I think you're all familiar with the latest EPI data and HIV data. Of the 36,801 new HIV diagnoses in the United States independent areas in 2019, 29% were among Hispanic Latinos. Now, when you look at this sample, most of the new HIV infections occur among men who have sex with men. Similarly, we see data on the right for transgender population, men aware of the trans experience. Most of the new HIV diagnoses among trans people were among Black, African-American trans women, followed by Latinas. So that's kind of the landscape regarding HIV. Now, structural intersectionality has been proposed as a framework to better understand these systems, right, and these structures and how they are tied together and linked to HIV outcomes. And here is kind of a snapshot of a structural intersectionality, examine the juncture of multiple stigmatized identities and overlap of institutional power structures that fall within or across several categories. One or more coexisting conditions or health conditions such as HIV, mental health, substance use, and childhood sexual abuse, experiences such as incarceration and pre and post migration experience, and social forces and structures, including stigma, discrimination, institutional racism, violence, and cultural imperialism. How this work emerged, I was in grad school and I was exposed. I was doing some research with recently arrived Latinos in Indianapolis, Indiana, and these are some of the quotes from that early on research and that highlight, right, the pervasive impact of systems and structures on access to care and HIV prevention and care. Many people won't go and seek out services because they're afraid it will affect their immigration status. For fear of being found out as undocumented immigrants, they don't go and seek help. Well, there are places you go and they don't serve you because you don't have a social security. One time I wanted to get a blood exam for HIV. They didn't want to do it because of the same thing. I didn't have papers, right? So it highlights once again the role of structures and systems on HIV prevention and care. I do want to do a big shout out to Dr. Lisa Bullock, a mentor, a colleague that has been pushing this idea of structural intersectionality. And here's a quote from her, right? We need to be talking about intersecting structures and not identities. Recognize that intersectional structures shape health outcomes, right? And she has done a fantastic job, highlighted some of her publications here and some of ours too, framing, right, structures and linking structures to health outcomes and less on the focus on behaviors, right? Are you going to use a condom or not, right? So just wanted to do a big shout out to her work. Now, what are we doing here in Philadelphia? The first one is Connecting Latinos en Pareja, a project close to my heart. This once again, this couples-based intervention for Latino male couples aims to address disparities in the HIV prevention and care continuum. One of the key takeaways from the project is it was guided by a community advisory board, and we conducted a total of 10 meetings throughout the course of the study, and this community advisory board informed all the steps of the research process, including the questions that we were asking in the assessment for study participants. Here's the snapshot of the study. Couples were randomized to the Connecting Latinos en Parejas intervention versus the wellness promotion standard conditions, and we had baseline 3 and 6 month follow-up assessment. Here's some of the recruitment materials that we implemented. One of the key takeaway and one of the added value of that community advisory board is that, this is their work, right? The result, this recruitment material is their product. This was a very humbling experience that I want to share. When I first started this project, I was coming from my postdoc in New York City at Columbia University, and I was coming with the idea that when you wanted to do research, HIV prevention research, sex sells, right? The whole idea of how to get these participants enrolled in clinical trials. So my thought was, let's include some shirtless Latinx folks in the recruitment materials. And the GAP said, hey, Cubanito, slow down, right? let's actually stop the hypersexualization of Black and brown bodies in research, right? And it was a very humbling experience for me as a researcher. Also highlights, right, the added value of community advisory boards in research, right, as well as in service, right? So just wanted to give a big shout out to that team. We also engage on social media networking apps, Tinders, Grinders, Craft. We have more than 10,000 followers engaged through our research pages. Here's the snapshot of the 4-session intervention, once again, delivered at the DIAD level. Session 1 goes through personal, cultural, and contextual influences on risk and HIV protection. Session 2 addresses communication and skills. And session 3 is about relationship strengthening for HIV protection. And session 4 is about social support for HIV protection. One of the key, another added value of the Community Advisory Board, they wanted to make it hot, fun, and safe, right? Like the whole idea that you must have hot, fun, and safe sex, moving away from this HIV risk discourse and frame sex from a positive standpoint, an empowerment standpoint, and presenting the prevention toolkit from that lens, right? Like how to have hot, fun, and safe sex. Here's all the alternatives that we have going on. And we embedded that language and that content throughout the 4 sessions of the intervention. Here's another activity and exercise for couples enrolled in the study. Was Mikasa exercise for the couple to identify influences, right? Influences, family members, the church, religion, politics, and how these systems influence you positively and not so positively. Case studies, right? And the CAP was really at the forefront in developing case studies that are relevant to the experience of Latino male couples, and using psychosocial tools like IDEA for problem solving, right? So just wanted to briefly highlight some of these case studies. The second project is the Trans Equity Research Project, once again, guided by a community advisory board. We engaged in scientific advisory board. We conducted in-depth interviews with peers in the local Philadelphia community, men and women of trans experience, leading this HIV prevention work. And we also conducted screenings and focus groups with 4 women of trans experience. Here's the snapshot of the session. The key takeaway for this is that, once again, the Juanito was coming in, behavioral, HIV prevention, testing, and these men and women of trans experience wanted to see life skills, right? So they wanted to see resume training, how to get prepared for a job interview. And we embedded that component as part of the intervention. So session 1 is self-care, session 2 is communication, but session 3 is about that life skills and professional development. Last but not least is a medical legal partnership project that we have going on. I know that La Clinica has been at the forefront of promoting this model of care, right? The whole idea of integrated approach to care and embedding the attorney, the legal component, the legal aid component as part of the healthcare team. MLPs offer a structural integrated intervention that could facilitate improvement in medical and psychosocial outcomes for people living with HIV. Through legal aid, MLPs can ensure that patients are able to access HIV services in a culturally sensitive manner. We develop a training. We're rolling out that training here in Philadelphia with 2 HIV clinics, clinics that serve people living with HIV. Here's the snapshot of the 8-session training that we put together for these clinics, including medical legal partnerships in action, health harming legal needs and how they're tied together to HIV prevention and care, integration of legal services in the healthcare team, and prerequisites for medical legal partnerships. That's almost the sessions here. Now, why an attorney? And here are the key takeaway, the added value of embedding the attorney in the healthcare team, right? Legal partners can address those health harming legal needs. Lawyers can prevent issues from becoming legal needs. They can advise and guide clinical staff, right, during the course of that patient care. They can be embedded as part of those case management teams, right, and advise that the medical staff on these health harming legal needs. present workshops, right, to staff on frequent issues that arise throughout the course of their work, and present educational workshops, know your rights, for clients. So these are some of the added value of the attorney in the healthcare team. Key takeaways, I know that I'm running out of time. We need to address critical gaps in the national Ending the HIV Epidemic initiative. I know that there has been a big push for that, but they're critical gaps. And this is the work of Dr. Guillermo Ramos, one of my mentors, colleagues that I admire. And this is their work, this is their data. 17 out of the 50 EHE local jurisdictions with most new HIV diagnoses among Latinos are not designated EHE priority jurisdictions. They account roughly for 1 of 10 new Latino HIV diagnoses nationally. So when thinking about epidemiology, when thinking about addressing the HIV epidemic among sexual and gender minority Latinos, we need to be thinking about these high incident jurisdictions. And now that 17 of the 50 are not, 17 of the jurisdictions with the highest new HIV diagnosis among Latinos are not included in the 50 EHE local jurisdictions. These are critical implications for HIV prevention and care, and how Dr. Guillermo Ramos framed it as the invisible US Hispanic Latino HIV crisis. We also need to focus on intersectional structures, structural stigma, racism, and discrimination that continue to drive the HIV epidemic among sexual and gender minorities. Continue the investment in the development and implementation of locally developed homegrown prevention and treatment interventions responsive to syndemic conditions and structural systems. I know La Clinica has been at the forefront of community health workers, right, promotores, and really pushing for this model. Galay in Philadelphia has been in Washington, D.C. with the Mark Hidson as well, promoting promotores models. We need to be thinking about integrated care models, right? Medical legal partnerships and so forth. We also need to support the development and training and retention of the diverse healthcare workforce, right? Latinx health, critical race theory, health inequities and new technologies should be implemented and should be pushed in healthcare systems. Strive to become a structurally competent, and this is building from Lisa's Bullock's, Dr. Bullock work. Develop an extra clinical language of a structure, engage in formal opportunities to learn critical theories, rearticulate cultural formulations in structural terms, observe and imagine structural interventions, and develop structural humility. With that, I'm done and looking forward to the Q&A session. Thank you.
Thank you so much, Omar, for the wonderful journey through the framework, intersectionality, your work, and the many areas that can touch upon. I do not have any questions in the chat as yet. So please don't be shy and enter your questions in the chat if you're attending this panel. But you also can raise your hand and ask your question either at the end of the presentation of each panelist or at the end of the panel. So I'll be here collecting and passing on to the presenters the questions that are entered in the chat. But I will be also letting you speak if you raise your hand and you want to ask your question directly to the panelists. Our next presenter is Serena Rejabian. She's an assistant professor in the Department of Public Health at the University of Massachusetts. Serena is going to share with us some data and discussions about employment and job security among Latinos, and I surmise, so I may suspect she's going to also touch upon the issue of intersectionality of that data with other sets of data. I know Serena is very familiar with. Serena, it's all yours.
Thank you, Dr. Felisola. Good afternoon, everybody. Can you hear me and can you see my slides okay?
Both. We can see
Thank
your
you.
slide and we can see you and hear you.
Perfect. Thank you so much. It's such an honor to be part of this panel with Catalina, Omar, and Danielle. So I look forward to our discussion, but I'm pleased to share with you, the title of my talk today is to share some of the work I've been doing across the country on addressing stigma and employment barriers for Latinx populations with HIV. The objectives I have today, I'm going to share with you some of the work I've been doing with the Health Resources and Service Administration through the Ryan White program. We've been looking at some of the key barriers to economic security for Latinx populations living with HIV. And I'm also going to talk to you about some of the strategies to address stigma, employment, and other unmet social needs. So before I get started, I just need to thank my funders at HRSA through the special project of national significance that's called the Improving HIV Health Outcomes through Coordinated Supported Housing and Employment Services, and thank the evaluation and clients and intervention staff across the country who participate in this initiative, and the Bureau itself at HRSA for funding this work. So before I get started, just a little bit of background. I don't know how many people are familiar with the Ryan White AIDS program that is funded in the US, but it is the payer of last resort for people living with HIV. It currently reaches about 500,000 people living with HIV. And you can see here, this is data from 2019 from HRSA. About a quarter of those people are identify as Hispanic and Latinx. And in terms of populations in poverty level, the Ryan White AIDS program, Latinos are one of the populations that are served. They're one of the most poorest populations reached by the Ryan White AIDS program, and giving them access to care and treatment. So it's a really important service for Latinx populations. And when we look at, in terms of the Ryan White program that have any sort of health coverage besides Ryan White, access to Medicaid, access to private insurance programs or other public insurance or even state funded programs, free programs, Hispanics and Latinos are have the lowest proportion that have access to any other type of healthcare coverage. So Ryan White, again, is an important service for people. And in terms of Hispanic and Latino women that are served by the Ryan White program, you can see overall, in terms of viral suppression rates, Ryan White clients, Latinas specifically, they're relatively high, around 90%, but there are subpopulations that have much lower rates of viral suppression, particularly those in the young adult population. This is among women, as well as those who are unstably housed. And so still reaching these subpopulations is really critical to achieve viral suppression. And among Latino men that are served by Ryan White populations, again, we see that some of the lower rates of viral suppression are among those who were perinatally affected, as well as are unstably housed. So in order to reach these subpopulations, in this initiative that is just currently ending, there were 12 demonstration sites that were funded to implement interventions to really improve housing and economic security, employment services. And the idea of the program was to improve engagement in care and viral suppression through providing housing and employment opportunities, and really try to reach particularly racial ethnic minority communities, including Hispanic and Latinx populations. So some of the data I'm going to share with you today is really hot off the press in terms of, we reached in this initiative over the last few years about 1,100 participants, of which about about a quarter were identified as Hispanic or Latinx. They were all unstably housed and identified as needing either, they were either unemployed or underemployed at the time they were enrolled into this program. And some of the factors that we found at the beginning what were some of the barriers in terms of their unmet needs that affected engagement in care. accessing HIV services. Number one was around just knowing where to go for services. Where can I find HIV medical care? Where can I find social support for housing, food, employment opportunities? More than half identified an unmet need for housing stability, and that many were doubling up, living with either with family members or friends. We didn't collect information around documentation status, but we know that many were doubling up with friends or reported to us through qualitative interviews that they had undocumented status. So that need for a stable housing instead of moving from place to place was really critical. And 41% identified an unmet need for income stability. Many had temporary jobs or working under the table if they could find any work at all. So this was a big factor we were focused on with this initiative. The other critical piece, a barrier, was around stigma. And in this population, we found 40% expressed internalized stigma. That means feeling ashamed or embarrassed about living with HIV and their diagnosis. Another third reported experiencing what we called anticipated stigma. They were reluctant to reach out for health services or other support services because of fear that they would be face discrimination in the community. So that just even prevented them from accessing services that they needed. And then 18% reported stigma related to their sexual or gender identity. And 15% reported experiencing racial discrimination. So this graph here, what we're showing is when we look specifically around employment and income stability barriers, what affects you? The blue bars represent from Hispanic and Latino participants, and the red bars come from other participants, either Black, African-American, white, or other races. And so we asked a series of questions about what was a barrier for you seeking employment. And you can see across here, the Latinos were, number one was fear of being able to take time off to see their doctor, or taking medications at work. There were also concerns around if working affecting their daily health and being able to address that. Finding a formal job, people were afraid if they got a formal job, they might not be able to get health insurance or coverage, or may not have access from the employer because of their HIV status. Just the stress of living with HIV prevented them from seeking work at times. And nearly half of our population, the Latinx population compared to other race ethnicities, reported just fear of having coworkers who would find out about their status. So these were some of the barriers that predominantly were significant for Latino and Hispanic populations compared to other racial identities. I also just want to share with you a specific case that we had of a client that we worked with in this initiative. This is a woman who immigrated from Honduras. She had no legal documentation. Her husband passed away. She immigrated with her husband and her children. And when she came here, her husband had passed away due to AIDS. She became the head of the household for 4 children. Two of her kids were twins that were perinatally infected. And then also she was living in a household with other family members who were unaware that she herself was living with HIV. At the time that she came connected into our program, she was facing foreclosure, or the household was facing foreclosure of where they were in their household. And she herself had no formal work experience. And so one of the interventions that we had through this initiative was working with promotores and navigators to connect participants to various housing and employment services. And so the navigator that she connected with she first identified some of the skills that, of this participant. What were her skills that she had from her homeland? That what did she like to do? What was her interest, and what kind of time and availability did she have to work? This was really important because she was the caregiver for 4 children. And they found out that their client, the woman, was really loved cooking. She cooked for her family. This was something she kind of aspired to do, was to have her own sort of business. And so through her navigator, they connected her with her some entrepreneurial spirit, helping her build connections and promoting a catering business for various agencies in the community. And in that, through that catering business, was able to triple her income. So, I share some of these strategies, some other lessons learned that we have that are coming out from this initiative and for us to think about. One was, and Catalina talked about this and Omar as well, that the role of these navigators and community health workers as part of the care team, but also in the community, is really crucial, not only for education around health and health services and where to go, but about these social needs and addressing these social needs and finding the resources in the community. This is traditionally the HIV care system does not have time. They don't have staff. The medical case managers may be too busy or overwhelmed to address with these specific needs. And having navigators or community health workers, promotores, do this can really provide that intensive one-on-one support that clients need. And that also helps them give support around disclosure. The other key lesson that we learned as a strategy was organizing, connecting people with job fairs and training programs. Omar and Catalina both talked about this. It just building their skills, and particularly the role of social media in terms of helping to find opportunities that women Latinx and Hispanic populations, and particularly women, may be able to find, because you can find jobs that work within your schedule and within other caregiving responsibilities. We also found, to Catalina's point about how the COVID pandemic affected our project. Our project was ending. We were in the last year of implementation right when COVID hit. And we found that for particularly many of our participants, but many of our Latinx participants, access to technology and having the Wi-Fi access and sustain that and paying support for bills so that they could maintain connection was really critical, either for their healthcare provider or just finding opportunities and addressing their social needs for themselves and their family. We also found that these, particularly for the Latinx culture population, we found that having opportunities because of documentation status, they may not have access to the same benefits as other people who, other racial ethnic groups. So providing seed grants to help individuals start businesses can really get somebody going and create that income stability and generation that folks need. And I think the other thing in talking with the projects, as I showed, our interventions were from across various states. And I think really we need to be advocating for change with our federal and state immigration policies and really looking for ways that we can create pathways for people with varying documentation status so that they have access to work visas, and other benefits. Pieces like SNAP benefits to help women who have caregiving responsibilities to take care of their young children. So it's not just about the medical care, because Ryan White is helping access some of those services, but these other social needs and benefits are really critical around housing and food, which in some states, depending on your documentation status, you might not have access to those benefits. And another key example is is the temporary protection status program, which has been extended under the current administration to 2023, which gives people work permits to be able to work and care for their families and their households. but it's not a permanent program, and something like this needs to be, and the level of benefits may vary across states. And so we really need to think about those sort of programs so that we can allow pathways for people to be able to work here without the stress and of fear of deportation and for themselves or their families. So I just want to say thank you. Here's my contact information, and I look forward to our discussion.
Thank you so much, Serena. We do have a question in the chat. Is very general, and I think we can keep it for the end. I think all the panelists could actually comment on it. I'm just going ahead and allow Daniel to do his presentation. Daniel comes from Portland, Oregon, or is from Portland, Oregon. He's worked with a specific subpopulation of Latinos. There are a lot of experience in healthcare, housing, service provision for Latinos in that area. So Daniel, please enlighten us.
If I get to unmute myself. Hello, everyone. Thank you. And thank you, Jesus, again, for inviting us, and Catalina, Serena, and Omar for your great presentation. Thank you so much. And yes, give you a warm welcome from rainy Portland, Oregon. But I'm really, really excited to be here today. And I don't have any PowerPoint presentations. My apologies. I do have some notes, so I will look down sometimes to read through them. But I'm going to expand a little bit beyond the HIV topic and keep the Latinx population as the common denominator here. And I will focus more on the behavioral health, both substance abuse and mental health, beyond the HIV piece of it. And I will focus on the area that I know the most, which is the Portland metro area, even though a lot of the information will resonate with the rest of the state of Oregon. So I've been a social worker for about 21 years now, maybe close to 22 now. And out of the first 8 years I was in Florida, in Miami, Florida, in the field of HIV. But for the past 14 years that I've been here in Portland, I have to say that I was very fortunate to join a team of behavioral health providers to put together a behavioral health program for substance abuse and mental health, specifically for the Latinx population in the local Portland metro area. So that was very exciting, and 14 years later, I'm happy to say that that program has increased, has become really robust in both the substance abuse and the mental health realms, and it continues going. I did that for 13 years, and most currently I'm now working for the state of Oregon, doing some equity and inclusion liaison and analyst work. And I also would like to say that I've been a consumer of behavioral health services as a Latinx person who also meets different identities and different intersectionalities. But most of my experience is from my professional experience working as the program manager for the substance abuse and mental health program, which is called Puentes, as bridges, and you know, and it was mostly it has been a really eye opener working with my own population. Coming from Miami, maybe not being very aware of these barriers and that we've been talking about today, but that became very much salient when I moved to Portland. Just to give you quick statistics around this area, in Oregon, we have a little bit over 4 million people living in the state of Oregon, but out of those, 500,000 people are Hispanics. So that's about 12% of Latinx living in the state of Oregon. And And based on certain reports and findings from Consumer Hispanic Affairs and reports from communities of color, we have identified some of the systemic and individual barriers and concerns that that Latinx face here every day. And out of the systemic barriers, just to name a few, there's the limited workforce and the lack of bilingual and bicultural providers. There is definitely a crisis in not having enough behavioral health providers, and those that can that are culturally specific and language ready to treat these folks are not there, right? So and you may ask why that is, and it may the reasons are many. One of them might be that we really are not doing a really good job to attract people into the behavioral health field. Another one is it's, you know, the salaries are not that attractive, right? So just a spoiler alert, we are doing a few things right now at the legislation level to and some House bills has been inserted to ameliorate that and to study the wages that behavioral health providers are receiving right now, as well as looking for ways to increase and improve the behavioral health workforce. Lack of adequate funding, I mean, again, talking about money on actually creating places and programs and treatment facilities that resonate, that are culture specific, and most importantly in that realm is to that there's a really lack of cultural relevant services, and especially services that require more intensive care, like residential treatment facilities for substance abuse or mental health services for Latinos experiencing severe and persistent mental illnesses, or SPMI. And as well as the lack of culture-specific integrated health services. So locations where people can receive both the substance abuse, mental health, and other ancillary services or physical health treatment. So not having that integrated care, it's a great systemic barrier. Why would you ask? Well, you know, a lot of folks may not have the ability to have the transportation to commute from one place to another. They have full-time jobs. Sometimes many of the people that we serve, they even have more than one job. They have a family. They have small children, and all these things are normal things that actually created great barriers for them to receive treatment. So having an integrated health treatment center, it would be more than ideal, and unfortunately there's not as many. So for the program that I worked for, it was one, you know, the only place, right, where people could receive culture-specific services in the Spanish language, where they could receive both substance abuse and mental health services. So of course, we were really loved by other providers and by our clients, because we definitely created that kind of segue or safety net, right, where they could come for those services all at once. Out of the individual barriers and concerns, and I believe that you all have talked about this in the previous presentations, but the fear of seeking services due to residential status. There are a lot of folks who do not have a residential status, so they feel that they might be penalized for coming to look for services. So unfortunately, they get to our doors when the problem is already quite advanced, right? Both the mental health and the substance abuse, and And also in the same lines of the lack of insurance and the inability to pay, sometimes they don't know that, well, sometimes because of the system, if they come from another county, or they come from not where we have the contract, right? Unfortunately, it's like, oh, sorry, we cannot serve you, and then trying to look for services. Otherwise, that would be for many times it was super difficult to do. But in reality, we were able to serve many people who did not have insurance, who did not a place that they call home, or they didn't have money to pay, and luckily through some county contracts we were able to provide these services. But the lack of knowledge of that stopped them a lot of times to look for these services as well. Lack of awareness of mental health services, or what mental health services is, also was a huge barrier. So many times I was in awe that a lot of people wanted the services, needed the services, but they really did not know how to approach the mental health aspect of it. So, that if I'm looking for mental health services, that means I'm crazy, and having those ideas. And it was more kind of providing some mental health 101 to these folks, so they could understand, the mechanisms of mental health. And the stigma with mental health and with substance abuse, it was incredible, and people really not treating themselves kindly, because of their mental health or their substance abuse. So when they would come to our doors, we wanted to experience that with them, and to be mentors, coaches, and guides to help them understand that it was okay for them to have a mental health or a substance abuse problem, and that we were there to help. Just to give you one of my early experiences here as an example, I had a client who he was not doing very well. He was not adhering to treatment, and he was kind of misbehaving a little bit much. So as a new manager, that was 14 years ago, as a new manager, I called him in to talk to him why he wasn't following the rules, and this and that and the other. And I was dumbfounded, because the first thing that he told me is that, yes, I know you're going to throw me out of the treatment because I am garbage. And I was incredibly affected by what he said. I just couldn't believe that he had said that. And we talked about it, and it was his own concept of calling himself that, and really processing that with him, and be able for him to see me as human, not as the one sitting in the office and in the fancy chair, right? But somebody who was there to help him, and to try to help him and connect him with the services that he needed. Let's see. So throughout the years, I have a little list of things that I have learned here throughout the years, and it goes with the science, and it goes with the research, but to make it a little bit more kind of personable here on the one-on-one of the things that I have learned. And the first one was we needed to treat people with kindness, and we needed to treat people like people, right? So at some point, our program was attached to this other program that was it was non-Latino. It was a DUI program for all kinds of other races and ethnicities, and I remember that our Latino folks didn't want to come in there, or they would feel really intimidated. One of them is because when they walked into the door, they needed to speak English, and they didn't know how to, or they didn't want to. So I was able to move that office into another office where it was just for us, and we were able to practice a lot of kindness, a lot of smile and warm welcomings. And do you want some coffee? Do you want some tea? Do you want some water? We also had some snacks, because there were people who did not had worked through the whole day or did not have a place to stay, and we wanted to offer them that, at least a snack, so they could be you know, to at least be present. Jesus, do you have a question?
No, Daniel. I would just letting you know that you are a little bit over your time, so we
Okay.
can have some
Perfect.
questions that are sitting in the chat.
Wonderful, and just to finish, it was a culture of no judgment, of understanding them with compassion and empathy, and as we build rapport, also build healthy boundaries, clear guidance, clear expectations with them, and it was always very, very much appreciated. So yeah, I think that's some of the things that I have learned. Sorry, I went over a little bit of time, and back to you, Jesus.
We all did. Thank you so much, Daniel. And wow, I've heard so much. We do have a couple of questions, actually 3 questions. And I'm gonna pass this one initially to Catalina maybe, but all panelists feel free to chime in because this question is broad enough to allow for everybody's input. It says, how would one even start a conversation or introduce some of these programs and workshops to integrate in a health system that is heavily holds stigmatized ideologies? There you have it. Is Catalina still with us?
Yeah, I thought that was an interesting question. And I think that I guess I would say we're having a moment in the health system right now. Even the systems that are most intractable are genuinely or by necessity having to learn how to say the word health inequity, racial injustice, transformation, you know, so I think there's opportunities now to say what this means for my community is, or here's something that I'd like to share at our next brown bag on diversity, inclusion, and equity, or what, you know, the DEI things. There's a space, and we have to grab it and not have it be really co-opted, you know, by people who are turning it into packages of how to do this kind of work, but not really going to the issues of, you know, who benefits from having a class of people who are excluded from immigration pathways, and why, and what is it going to take to be able to change those structures beyond education, you know. So I think we have to seize the moment, and there's no end to where that might take us.
Thank you, Catalina. Any other panelists that want to comment on that question?
I just want to reiterate something that Catalina said earlier, and I think Omar, you brought, and Daniel, all panelists brought it up, but I think one way to start is just bringing in your community's voice, and hopefully you're in a place where your leadership will listen to that. We are in a unique place, like Catalina said, but I think if you can start bringing in that voice and finding safe places, and then you yourself have confidence to bring it up to leadership if they're not already asking for it. I think that's where power starts and change, and bringing and starting to address some of this stigma. But it just takes time and patience, and we do have to seize the moment. But I think if there's persistence and perseverance, it will happen. We bring those voices in.
Takes a village.
Yeah, I couldn't agree. I couldn't agree more. And just to reiterate the importance of clients, right? So how to crack these health systems with this internal stigmatized identities, you know, engagement of clients, and really bringing in clients and engaging clients in that change. You know, here at Temple, for example, students have a lot of power, right? When the call for health equity started with the past 2 years, right? The students wanted to see more courses reflecting of that discourse, right? And the students wanted to see a course on white supremacy and how that impacts practice, social work practice. So now we have 2 courses on white supremacy at the School of Social Work, but it was the students who initiated that process, right? Same with the CIS healthcare systems, right, and structure. Usually these administrators will hear to the clients, right, what the clients want to see and demand. So that could be a good strategy, engaging those existing clients. Also data, right? Data supporting and linking how this program and intervention is linked to positive health outcomes, right? So these administrators see a gain, right, with these news programs or interventions. So just two takeaways there on how to crack the systems. But I agree, like Serena mentioned, it takes times, right? And it's a challenge.
There's a question specifically for Omar. He says, Mr. Omar, that particular article is on 2019. We need to do it for 2021. We would like to know recent HIV information on older people like me. I guess that you could respond to the first half of that question. I do have another question for Daniel if we have enough time. Go ahead, Omar.
No, just excellent points, Alberto, and I couldn't agree more, right? The importance and the need to serve cis, heterosexual, self-identified people, older people living with HIV. And that's why I shared, that's an article, but SAGE is an organization in New York City that serves people living with HIV. They have a lot of advocacy work. I have a few contacts there, so maybe we follow up and I can share those contacts with you as SAGE, an organization that is once again heavily focused on older people living with HIV. Another resource, Maria Mejia, which I think you probably know her. She's an activist, someone living with HIV, Colombian. She's very active on social media, and she has established this network, social network of support systems. She has like 2 Facebook groups that pretty much like every day you go into it, there's like 20 post support systems. So she has been able to leverage in social media tools to support older people living with HIV and self-identify cis heterosexual Latinos.
Great, thank you so much. And I think we have time for a final question. Daniel, this question is for you. Is HIV related stigma different than mental health stigma? And if so, how?
I think that there's certain elements that, of course, are going to be different and depending on from person to person, individual to individual, and case to case. However, I think that the looking at these elements of stigma should be looked, into as in general, right, and be able to tackle, what are the common denominators on the stigma and how it's affecting treatment, looking for treatment, finding treatment, etc., and as well as looking at the individual elements that this particular person may have.
Great. Nor do I have questions myself for the panel. Excellent presenters, great individuals and researchers, program administrators, so on and so forth. Thank you so much, panelists, for your presentation, for sharing all that wealth of knowledge and expertise with us, myself included. And if there's no further question, we can give people a couple of minutes back. It's 4:56. Hearing none. Thank you so much. You guys want to say bye to everyone? Bye, everyone. Thank you so much.
Thank you so much,
everyone.
And thank you, Patty, and International Conference on Stigma for inviting us. Have a great rest of the day.
Thank you, Jesus.
Thank you, everybody.
Bye. Thank you for coming, everybody.
Bye, Catalina. Bye, Daniel.
Bye. 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 Bye.